Thank you, Mr. Chairman. It's a great pleasure for me to be back in Israel. I had the luck to be trained as a cardiologist in Israel many years ago in Kfar Saba, and what makes it so special is that two of my senior attendings are here sitting in the audience, so I better give a good talk. So I was asked to talk about the value of 3D imaging when we assess the mitral valve. I think it's a little bit of history is always good. You know, echocardiography was actually initially described in 1953 by Dr. Inge Edler in the city of Lund in Sweden. And he was inspired by the use of sonars in the Second World War. And this is just a little bit of a picture of our initial visualization by Dr. Edler about 60 to 65 years ago of the mitral valve. And when you think about it, you go now to about 10 years ago, this is sort of the way in which we can image the mitral valve. So you can see that cardiac ultrasound has truly advanced very nicely and steadily over the last 65 years. I would be remiss to tell you that Dr. Inge Edler did not get the Nobel Prize for his invention together with Dr. Hertz. And the story goes that if you come from Sweden, you have to do a double contribution in order to get the Nobel Prize. The Matrix TEE probe, which has been a fantastic phenomenon around the world because it has been accepted everywhere, was only introduced in the year 2007. So that gives you a little bit of an idea. Things in ultrasound usually do not move very quickly, but the invention of 3D echo has really become very popular because it really offers new type of information. Let me see if I can go back to the, okay. So one of the biggest advantages of 3D echo is the fact that you can present the mitral valve in a manner that is extremely similar to the one that the surgeon views the mitral valve at the time that he or she opens the chest. We have nicely learned about the structure, the aortic mitral curtain, that puts together the aortic and mitral valve. We have learned about the relationship between the mitral and the aortic valve. We have seen the anterior mitral valve leaflet, and we now understand that the posterior mitral valve leaflet is divided into 3 scallops, P1, P2, and P3, and the same scallops get the same names in the anterior mitral valve according to what they antepose. There are very few diseases in cardiology that 3D echo has had a major impact. And I think that degenerative mitral valve disease is definitely one of them. We all understand that degenerative mitral valve disease is a disease of excess tissue. And on one side of the spectrum, we can have fibroelastic deficiency. And on the other side of the spectrum, we have Barlow's prolapse. 3D echo has taught us that in some instances, the disease can affect just one scallop of one leaflet. And when you go to Barlow's, you can see that there is an effect of multiple scallops that involve both leaflets. 3D echo has been really a fantastic tool for us to be able to measure many things about the mitral valve apparatus that we were not able to measure in the past. So we can measure both the diameters, we can measure the surface of the leaflets, we can measure the height of the saddle-shaped mitral valve, we can measure the apposition of both leaflets, and we can also measure the angle between the aortic and mitral valve. The more acute that angle, the bigger chance you have of ending with systolic anterior motion of the mitral valve after you have a mitral valve repair. Well, we had the opportunity of developing a lot of these mitral valve parametric maps. And this, I think, is a very good tool for communication. Whenever there is a displacement of part of the mitral valve apparatus towards the left atrium, these get color-coded in red. And you can see very nicely here how you see a P3 prolapse. You can see here a P3 that spills into P2. And here you can see more of a Barlow's prolapse involving every scallop. We can also look at the shape. This is a normal mitral valve that has a saddle shape. Here you can see a valve with ischemic mitral regurgitation in which the mitral valve is enlarged and is flat and has lost its saddle shape, whereas the papillary muscles are displayed. Well, as we all understand, particularly when you are in Israel, that God is a very intelligent person, if you wish, and he made the mitral valve to have the saddle shape because the shell shape is phenomenal in terms of reducing the stress on the leaflets. And we and others are now working on many different types of models to try and understand the regional stress of the mitral valve leaflets, to then understand how different rings that have different morphologies and different shapes affect the regional stress of the mitral valve. When we communicate about mitral valve pathology, we usually use a classification that is based on Carpentier classification that divides mitral regurgitation into 4 types, and then there is an additional 5th type. And I will show you some examples. Type 1 is a type in which you have normal leaflet motion. In type 2, you have an exaggerated leaflet motion. In type 3, you have restricted leaflet motion. And let me show you just briefly some examples. This is an example of a patient with a dilated cardiomyopathy with a very dilated annulus. And here you have mitral regurgitation because the annulus is dilated and there is poor coaptation of the mitral valve leaflets. And you can very nicely see that irrespective of whether you're looking at the mitral valve from the left atrium or you're looking at the mitral valve for the left ventricular perspective. Other examples of type 1 is an example on the top of this slide, which is an example of a patient with bacterial endocarditis who underwent a perforation of the mitral valve. The clue is that the jet of mitral regurgitation is originating not at the point of coaptation, but at the bend of the leaflet. And in the 3D echo, you can very nicely see that perforation that looks like a crater on the mitral valve. Interestingly, as we started imaging the mitral valves, we start to see that many times the small indentations that you can see in a normal mitral valve are more profound, getting to the base of the annulus, similar to what we would call a cleft mitral valve. It's very important. 3D echo allows you to make this diagnosis and tell the surgeon, because correcting this will prevent a protracted mitral regurgitation after surgery. I think when we talk about the spectrum of degenerative mitral valve disease, we should definitely pay homage to Dr. Barlow from South Africa, which without the use of echo made excellent sort of diagnosis. And this is a picture taken from an article in 1985 by Dr. Barlow, in which he already, by using predominantly the stethoscope, make the diagnosis of the difference between a prolapse and when you have a flail mitral valve, and different types of flail mitral valve, which he called sort of a Barlow's prolapse with a flail mitral valve. And a lot of his classification and his thinking is still something that has remained. This is a nice example of a 2D echo of a patient with Barlow's prolapse. This is a 42-year-old patient complaining of decreased exercise capacity and of recent duration, and you can see all of the echocardiographic characteristics of a Barlow's prolapse. Now, when you look at this in three-dimensional echo, you get the idea that there is definitely a dilatation of the annulus with excess leaflet tissue. The predominant issue here is billowing and not prolapse. The leaflets are thickened as well as the chordae, and as I mentioned, you have a large annulus. So please take into consideration, now I will show you the operating image of that particular patient, just to give you the idea of this gigantic scallops presented in this patient with Barlow's prolapse. And as you look at this image, it becomes sort of very apparent to you that you need to have a very skillful surgeon in order to make a successful repair. In the United States, there is a lot of discussion that many of these patients for mitral valve repair should go to hospitals that have quite a lot of experience doing these repairs, and usually the vast majority of surgeons in the United States do less than 25 of these repairs, which seems to be the magical number that you need to do. On the other side of the spectrum, you have fibroelastic deficiency, which is a disease of older patients. Usually these patients have a short history of mitral regurgitation. The predominant lesion here is either a ruptured or an elongation of a single cord, and the remaining segments of the mitral valve are usually normal. This is a professor of physics at the University of Chicago who liked very much to cycle. He decreased his exercise tolerance, and you can see here that this patient has a very nicely seen P2 prolapse, which would be easily repairable. This is an example of a fibroelastic deficiency due to a ruptured cord. You can nicely see the prolapsing part of the valve and the ruptured cord, and exactly the same type of finding at the time of surgery. Our group, as well as many other groups around the world, have been able to show the close relationship of what you find in a 3D echo together with what you find at the time of surgery. This is an example of a patient with a fibroelastic deficiency with a P2 prolapse that has 2 ruptured cords, and you can see very nicely the area of where this prolapse is occurring and how this affects the line of closure of the mitral valve. So I think we have learned a lot, and when you compare fibroelastic deficiency with Barlow's disease, usually Barlow's disease is a disease predominantly of women, usually less than 60 years, with a history of mitral regurgitation that usually exceeds 10 years. And as I told you before, the leaflets are thickened and have diffuse excess tissue, and this is a multi-segmental disease. Quantitative echo has been also, 3D echo has been also extremely useful, and if you actually measure with 3D echo the amount of billowing height and also the amount of billowing volume, and you plot one against the other, you can see very nicely that you can separate patients with fibroelastic deficiency, that they have billowing height but don't have billowing volume, and that separates nicely with Barlow's disease that of course will have billowing height but have much excess volume. So I think another thing that we have learned is that three-dimensional echocardiography can very accurately predict how complex is the mitral valve repair. This is a study that we did together with David Adams, which is a very accomplished mitral valve repair surgeon in New York. We took a lot of his patients, and he decided which repairs were complex, and he defined them, and then we looked at the three-dimensional findings. So a mitral valve repair is complex whenever you have a multi-segmental involvement when it involves the anterior mitral valve, when there is a scarcity of leaflet tissue, when you have severe calcification, when the prolapse height is enlarged, or where the annulus is extremely dilated. So let me show you here a very nice example of an anterior leaflet prolapse, which would make a very difficult repair. A Barlow's prolapse, which as mentioned would also make a very difficult repair. This, in the top, you see a very nice example of a medial commissure prolapse. You can see here exactly where it is located. And those are also extremely difficult to repair. And this is the most typical, yet the most frequent type, which would be a P2 flail or a P2 prolapse, which is the one that is more easily repaired. ECHO has also allowed you to separate what the different operations do to you, and this is an article of Dr. Ben Sekri from Israel when she was in Houston. We collaborated in this particular study. When you compare the Carpentier classification, Carpentier's operations are usually were dependent on leaflet resection and the use of a partial flexible ring. Whereas now there is this American correction in which you use a full flexible ring and you use artificial chordae usually instead of leaflet resection. When you quantitate that using specific software, you can see that the American correction seen here in black actually preserves the motion of the mitral valve apparatus, whereas the Carpentier classification with the resection, approximation, and suture actually does not allow the normal motion of the mitral valve apparatus. You could say, well, we need to follow these patients for a long time to see if this really sort of makes a difference in outcome. I would like to sort of finish with a couple of slides just to tell you that three-dimensional echo is extremely useful to look at the submitral apparatus. For many years, we thought that 2D transesophageal echo was not good to look at the submitral apparatus. If you do a transgastric views in the long axis, you can very nicely look at all the aspects of the submitral apparatus. And there are a couple of studies that we did in our group in which we did actually very nice comparison of the different types of what you see in 3D echo with what you see at the time of the operating room, with the idea of predicting the length of the submitral apparatus to have these corneal cords already prepared. Chronic mitral regurgitation, as you look at the guidelines, is very important that you initially make a different diagnosis between degenerative and ischemic mitral regurgitation, because these conditions are very different, and 3D echo has been extremely useful, again, in the diagnosis of functional MR. This is an example of such a patient, again, with the loss of the saddle-shaped mitral valve. You can see very nicely here that the apposition of these two leaflets is almost null or disappeared, and that the mitral valve apparatus are very decided. This is also some software that was developed in order to look at the mitral valve apparatus, and it is important to see that in ischemic mitral regurgitation you can actually look at two different types. You have the symmetric or the dilated cardiomyopathy and the ischemic mitral regurgitation, in which you have the longer tethering length and the wider angles. Tethering length is the distance between the tip of the leaflet and the papillary muscle. So I had the opportunity now to talk here with Dr. Yosefi, who a long time ago made this initial description, but I think we all know that we use mitral regurgitation in order to look at the area of flow convergence in the vena contracta. We also understand thanks to 3D Echo, that a lot of these measurements are wrong, and you can see now that the vena contracta and the area flow convergence have an oval shape. So I would like just to finish to tell you another small observation. 3D Echo allows you to look at this structure, which is the aortic mitral curtain, which is the structure that puts together the aortic and the mitral valve. And just to show you that a lot of software has been developed in order to look at this interaction. And this is a nice observation. People have described that after TAVR, many times there is a reduction of mitral regurgitation, and people didn't understand that. I think with using this program, it becomes clear that as you expand the aortic valve with a TAVI, you change the shape of the mitral annulus, and the anteroposterior dimensions get smaller. And this is just an example of a 3D echo of a mitral valve with mitral regurgitation before the TAVR, and after the TAVR, you can see that this dimension is reduced, and there is much improved apposition on both of the leaflets. So I would like just to tell you and to finish that 3D echo has rapidly disseminated. We have learned a lot about the mitral valve. We have done a lot of volumetric quantification. We guide a lot of percutaneous procedures. Where are we going in the next couple of years? You're going to see that 3D echo will become the method that is going to be used in order to quantify regurgitant lesions. A lot of the software that I show you today takes quite a lot of time. It needs to be done in an automated way. 3D echo still has not shown that outcomes are changed, and this is something that echo does not do very well. And I think that 3D printing will allow in the near 1 or 2 years the ability to make really custom prostheses that I think will further improve the guidance of structural heart disease. Thank you very much.